Hello and welcome to Season 2, Episode 65 of the Physician Assistant Exam Review Podcast. This week, we're going to be continuing our discussion of the eye with a couple of traumatic issues, and we'll pick it up from there. All right, so my name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review. This website, this podcast is designed to help you pass your exams. We talk a little bit about clinical practice, but the reality is I'm here to help you pass your exams. I'm here to help teach you how to study. I'm here to help teach you how to take tests. I'm here to do that in the realm of medical content. I'm also here to tell you you're not alone. There are thousands of other people, tens of thousands of other people listening to the show, lots and lots of people who are in the same position as you, struggling, trying to figure out how to make the most out of this. The more I talk with, I've been talking with PAs for years and years and years now, but the more I talk with people, the more I start to realize almost how isolating everyone is, how alone everybody feels out there. Even when you're in school, I always thought it was more when you're taking your PANRE, but I found in a very recent discussion with a PA how isolating just PA school can be when people get their scores back on their exams and yours are lower and you don't want to share them and that sort of thing. So I just want to let you know that everybody's in the same boat. This stuff is hard. It takes up a ton of time. It's ridiculously difficult. And you're doing great just to be here. So let's build up from there. Part of where I'm getting this from is I just did my second interview for this podcast. That won't be coming out for a little while, probably episode 67 when I finish the eye. But because I got such great feedback on the one we did with Elena where she had failed her PANCE, and that was episode 61, and she talked about all the things she did to bounce back from that and create a great life for herself following that, essentially traumatic experience. I had someone else reach out to me and tell me that they had actually failed in their first semester, had failed and been asked to restart the program. And so I had a discussion with her, and it just amazes me how difficult this can be and how strong people can be to get through it. So anyway, that'll be episode 67. I'm going to go ahead and release that interview, and I'm absolutely looking forward to that. You're going to get some great information from there. Anyway, let's pick up and move forward with our discussion of the eye. We are just about wrapping up the eye. Actually, these last two will be a little bit shorter, I think, because the way that I spread things out. But that's okay. Like I said, I kind of like to keep these short for the content part, because I think it helps them stick into your brain. I know some people like to just slam through content, but like I said, I talk a lot about study tips and the way to move through things, and breaking it up with a little bit of color certainly helps make things stick in your brain. Anyway, we're going to begin with our priming questions. What test should you order for a suspected orbital fracture? What test should you order for a suspected orbital fracture? Which eye issue is a common post-operative complication? Which eye issue is a common post-operative complication? Define hyphema. Define hyphema. Now we're going to begin with blowout fractures. This is the fracture of the orbit. Clinical presentation. This is usually somebody got smashed in the face, right? This is not something someone's unaware of and comes in for a routine exam and you discover a blowout fracture. That's not the way this works. So sometimes it's easier to picture how the patient's, not just their presenting symptoms, but how they're going to present. This isn't someone who walks into a GYN office, right? This isn't someone who walks into a family practice office. At least I hope not. This is somebody who walks into the ER having taken a baseball bat to the face, having taken a hockey stick to the face, something along those lines. They're obviously going to have ecchymosis. And again, this is one of the things I talk about. Don't harp on all of these details. Do you have to memorize that a blowout fracture is going to have ecchymosis? I think that's something you can probably deduce on your own. They're going to be swollen. They're probably going to have a black eye. The difficulty with vertical eye movement is one I'd hold on to. The diplopia thing makes sense, and that has to do with that difficulty with moving the eye. Infraorbital anesthesia secondary to trauma to the infraorbital nerve. That one you may want to hold on to. Again, swelling, subconjunctival hemorrhage. Those are things you should probably just kind of know. And I don't add that kind of stuff to my list of things to know. It's just here to add some color to the description so you understand what's going on. Labs and studies, physical exam findings. So you're going to get an X-ray. The orbital floor fracture may show a teardrop sign, which is the herniated orbital contents coming through that fracture, may or may not. And then you're going to want an orbital CT. You're going to want a CAT scan, because if it needs to be fixed, the surgeon's going to want a CAT scan to know what bones, what needs to be done exactly. Treatment. This can be monitored depending on the fracture, right? Not every fracture needs to be fixed, despite what some people will believe. They don't need to be. If it's everything's still in place, then you can just keep an eye on this. Prophylactic antibiotics may be given because all this stuff, these bones are right up against the sinuses, right? So there's a lot of transmission of bacteria across there. So you maybe want to give some prophylactic antibiotics, and then surgical repair may be necessary. I've done a handful of these. I don't do tons of them in my day-to-day job. We do some, and it's kind of cool because all it is you drop a plate in underneath the eyeball. You make a small incision and drop a plate in there. And I don't do a lot of eye work, so this is one of the few times that I'm in that area, and it's kind of a cool surgery, and the plate is really neat. All right, next, the foreign body. So again, this is pretty straightforward stuff. I don't think you need to kill yourself here to memorize foreign bodies, right? How do they present? Well, if you stop and think about it for just a second, I think you will have a good idea how this patient presents. They come in complaining they've got something stuck in their eye. Lab studies and physical exam findings. You should do a visual acuity test as soon as they come through the door so you have a baseline to work from. You can give them a topical anesthetic. A fluorescein stain may be helpful to try to find that object. A Woods lamp, slit lamp, all that stuff can be helpful. And if it's a little piece of steel, they may have a rust ring around the object. A sterile wet cotton tipped applicator can be used to remove it, or a hypodermic needle, which always freaks me out, but I kind of get it. You can get a bacitracin ointment, should be applied. And then you can use, and then one of the things you kind of want to avoid, and I'm surprised how much going through this is the answer, is you want to avoid eye patches in these cases because they actually lead to an increased rate of infection. If a patient has an intra-ophthalmic foreign body, this is not something you take out in the office, right? If they've got something sticking out of the eyeball itself, then this is going to go to an ophthalmologist. Corneal abrasions. These are most likely caused by trauma. They got poked in the eye, or as I alluded to in our priming questions, this is something you can get from surgery, and it's not really from the surgery, but it's from I don't want to. My anesthesia friends would be mad at me if I blame them. But what happens is the patients are sleepy, and so when they wake up, and usually the first thing they want to do is rub their faces and rub their eyes. And you can wind up with a corneal abrasion because they're really still pretty out of it. And that's how we get a lot of post-op corneal abrasions. So if that happens, because the corneal abrasions can be very, very painful, they will have, let's say, a gallbladder removed, and the only thing they'll be complaining about is their eye because it's so painful. So we do everything we can to avoid allowing patients who are just waking up to touch their faces, but sometimes you can't win. So the patient will come in. This is someone who will walk in either, post-op, or will walk in to your office and say, I got poked in the eye and now I'm having a ton of pain in my eye. And this is someone who may come into a family practice office, right? Or an urgent care or an ER, and they have severe pain. They have photophobia. You're going to evaluate them just as if it's a foreign body, right? Because you don't know ahead of time whether it's a corneal abrasion or a foreign body. The presentation is going to be pretty similar. They're going to come in complaining of something in their eye. They may have had a little trauma. They may have a story that'll support one or the other or both, right? So it's a little hard to differentiate these two on just with the conversation. So you're going to look at it as if it's a foreign body. You can fluorescein stain it, and then the abrasion will become darker than the rest of the cornea, so you can diagnose it that way. Treatment is going to be just leave it alone. Most will heal in a couple of days. And again, that bacitracin ointment will help. NSAIDs for pain. And once more, eye patches lead to an increased rate of infection, so we're not going to patch these. But we do need to reassure patients because these are pretty uncomfortable and very, very painful, but they will get better in a couple of days. But they're really annoying. Our next and last one for today is hyphema. This one's always just easily stuck out in my head, and it may just be from the pictures you see when you look at the pictures of this because they're kind of disturbing. This is blood in the anterior chamber. Most frequently, this is traumatic. And the key here, and the way this is going to come up on your test, if it comes up at all, is in a kid, this is child abuse until proven otherwise. There are other reasons you can get blood vessel abnormalities, just like speaking abnormalities. You can get cancer in the eye. You can get sickle cell, which can also cause this. Those are some other causes aside from trauma, but really what you're thinking about initially is trauma. Clinical presentation, again, blood in the anterior chamber, vision abnormalities, pain, and photophobia. You are going to want to measure the intraocular pressure in these. And these will tend to get, if it's not some other underlying cause, these will get better. The blood's reabsorbed in a couple of days. You want to sleep with the head of the bed elevated, maybe 30, 45 degrees. And you're going to recommend the patient not read or watch television. And these you are going to want an eye patch. This will help them. Wow, that was quicker than even I was suspecting. So that runs us through part 4 of the eyeball. Before we move on to the answers of our priming questions, I am going to run through today's study tip. All right, I had a little technical difficulties there. But our study tip for today is where we're going to go next before we answer our priming questions, which I'm hoping you should have been able to get from the show today. It wasn't how long you should be able to hold on to that information. Anyway, one of the things I want to talk about is the feedback I got on this month's, which is the March edition of the Physician Assistant Exam Scholars newsletter. That's the monthly newsletter that goes out, shipped in the mail. And it has been great. And one of the reasons it's been great is because I covered some stuff that was not common knowledge as far as studying goes. Some very, very kind of different ways that I go about things. And I'm shocked at the number of people who, one, can't see those things, can't do those things. And two, the number of people who don't do the normal things, the average things, the things that make stuff stand out. And one of the things I got from interviewing some of the PAs who have not done well is they, and tons of PAs I talk to, PA students I talk to, have always been smart, right? To get this far, you've got to have some brains. You have to have some ability to take tests. You have to have some ability to study. And for most people, this is not something they ever had to take seriously because they've always been smart enough to handle it. And what I have found over the years is that makes it so that when you get to PA school and things are cranked up and it's really difficult, you have no clue how to actually study. You have no clue how to make things easier, how to make things better. And what I'm finding is, and what becomes apparently obvious, is people just bang their heads against the wall and try to do more and try to stay up later and try to work harder. And that works up until a point, but not forever. So anyway, today's study tip is going to be in an effort to help you to understand a couple of, at least one basic. And this one is pretty simple. And the idea is you should have, I've talked a lot about location of study, where you study, the things around you. But this one is to change the place where you're studying in from time to time. And the reason for that is it will give your brain some things to latch onto. It'll give your brain places to sort of store the information. It's not quite like a memory palace, but it's a lot like, or rather, it's what happens is you ever have that feeling when you're trying to remember something and you can see the textbook it was in and you know that it was on the left-hand side of the page and there was a picture on the top, and eventually you get to your answer, or maybe you don't. But you have some other information you can use to feed your brain back and follow that path back to the memory. Well, changing your study location does the same thing. You'll get a flash of the place you were in, and you can use that to say, oh, you know what? That day I was studying ENT, I was sitting at the kitchen table that day. Okay, so what was I covering? This was, and that sort of helps walk you down that path. I find that's really helpful. For me, I know when I'm listening to podcasts, that really sticks. I can remember what road I was on or where I was going, and that helps some of the information stand out to me. It's weird, and I don't do it on purpose. I don't try, and maybe I should. Maybe you could get even better at this if you use it like a memory palace. But what I find is just being in those different locations gives my brain, it's the same as if your textbooks were printed in black and white, just text, no images, no nothing, no bullets, no headlines, no changes in fonts, just the same thing over and over and over. It would be impossible to remember. You don't understand how much your brain latches onto all those different cues and how helpful that those variabilities, that change is. And changing your site, your location of your studying will have a similar effect. All right, let's close it out with answering our priming questions. Hopefully these should be pretty easy for you. What test should you order for a suspected orbital fracture? What test should you order for a suspected orbital fracture? That's going to be a CAT scan. Which eye issue is common postoperative complication? Which eye issue is a common postoperative complication? That's going to be a corneal abrasion. And then define hyphema. You may have forgotten this one if you haven't studied it a lot. But it's blood in the anterior chamber of the eye. Blood in the anterior chamber of the eye. All right, great. That'll wrap up episode. I still can't get it out. 66 and 65 rather. We'll have 66 out for you soon. That'll wrap up the eye in general for us, or completely for us, and we'll be able to move on from there, which is super exciting. I'm really thrilled about that. If you haven't done so, please head over to the website and sign up for the email list, www.physicianassistantexamreview.com. I put out tons of study tips, tricks, ways to improve everything you do in PA school and after. Those come out almost every single day, and you definitely want to get your hands on that. If you haven't, please get over there and sign up for that. You'll be very happy that you did. Anyway, take care. Until next time, good luck on your exams, and I can't wait to hear how you do. Take care.